Thank you very much. Thank you very much to the organisers for inviting me. It's a pleasure to be here, and I very much hope that, to be able to share with you what I see really as a day-to-day, week-by-week challenge for me and many of my patients in this whole arena. Just to give you a sense of my experience, I looked back over the last 12 months and I've seen around 250 new patients with Ehlers-Danlos syndrome, of which within, and these are complex patients, this is tertiary quaternary referral, and within that group there were around 30 patients where I felt there was a need to explore them further because of the concern over the possible presence of craniocervical instability. Of those 35 went on to eminent colleagues of mine with me asking the question, is there a need for neurosurgical assessment and neurosurgical intervention? Not with any expectation that neurosurgery was needed, simply asking the question because I'm not a surgeon, I'm a physician. None of them had surgery. None of them were considered to need surgery on the basis of all the findings. In my clinical practice in total, I have thousands of patients with EDS and HSD. I have 2 who have had surgery for craniocervical instability. Both of them did reasonably well in their symptom profile after surgery, but 6 months later, both of them were worse. So I have a really challenging personal experience of this whole world. What I want to do is share that with you. In so doing, I must say a big thank you to people like Anne McCarthy, who's here in the room with us today, senior physiotherapist, many of the physiotherapists that I work with and allied health professionals, and conversations around the world about the complexity of this. Because I do think, from my perspective as a physician, that this is extremely challenging. And I'm aware from my practice that the vast majority of the patients for where this may or may not apply actually remain under our care in conservative physician land and allied health land, even post-rehab, and not in the world of surgery. So I place that caveat in the context of really wanting to explore what we do when we don't do surgery, because I think that probably affects the vast majority of our patients. So with that introduction, I have a very grandiose title, and if there's any expectation that I'm going to answer all of these questions for you and land it and we can all go home happy, that is not the case. I have actually reflected and have a very large number of questions that I want to share with you in a short space of time, and so I wanted to change the title of my talk and make it this, because I think this is where I'm at, even as an expert within a tertiary quaternary centre. And I'm really grateful just for the opportunity to chat about this in this kind of forum with this wealth of expertise. So I had put in that I was going to talk about causality, that I was going to talk about treatment and an outcome, and I will do, but I'm going to talk about it in the context of the challenges that I think we see. So within the whole sort of process of thinking about causality, it isn't difficult, I think, for us to conceptually understand that one of the underlying pathologies must relate to the propensity to laxity, to the support tissues, to the muscular structure, possibly even bony dysplasia. I think we all get that in terms of a broad principle, and that's very much the world we're working in with collagen connective tissue diseases. The question that I have, though, with the vast majority of my patients is, okay, we have a diagnosis of a syndromic condition where there is a propensity towards soft tissue laxity, etc. And it may well be going on equally within the apparatus of the cervical spine and the craniocervical junction. But actually, in the context of any hypermobility-related disorder, what actually is the definition in that patient group of craniocervical instability? And when I tried to sort of ask that question of myself is, well, I realise that I don't actually know whether the hypermobile population as a whole, who presumably are the broadest platform of representation of tissue laxity, are different from the general population or the non-hypermobile population in terms of their clinical findings and their imaging in this whole world. It comes down to the question, in my mind, am I looking at instability, or am I looking at a normal variant of hypermobility and laxity in a population that otherwise, the vast majority of the time, might be well? I don't know, because I'm sitting in a tertiary or quaternary clinic, and the patients that I have in front of me are extremely complex, and my impression of the world is totally biased by the complexity of those cases. I don't know what's going on in the rest of the world where there may be a sense of normality even within this patient population. So then it begs the question for me, what is the relationship between any difference that there might be and symptom presentation? Why might it be the case that I could do an upright dynamic MRI, for example, on one patient and identify relatively mild features but have somebody with very severe presentation of symptoms, and completely the opposite? And it reminds me of the whole story that we had in rheumatology around the radiology and osteoarthritis. You can do an X-ray of a knee and it looked pretty benign on the X-ray, but the symptoms are profound in the patient, and vice versa. And we have this challenge, and I don't have an answer. I'm posing it as something that we need to be thinking about. And then there's the difference. Is there a difference then in criteria, how we define the whole concept of craniocervical instability that's specific to this population? So if I start there, it clearly already, I think, gives an impression that this is a very difficult conversation for me to have with my patients, because there's lots and lots of questions that I don't know the answer to. What about sort of history from a causality point of view? I think, again, it's sorry for the pun, but it's a no-brainer to me that if somebody presents with a history of trauma, who has EDS, who has had a major whiplash injury on top of maybe previous neck symptoms, or has even been asymptomatic in the past, that there may well be some form of new instability that's a direct result of the trauma, and that would make sense. However, for the vast majority of my patients, most of them would seem to present with a very gradual onset of symptoms, and a very variable onset and a very variable progression of specific symptoms. So they don't all sort of appear at the same time, as if somehow there is a sudden acute neurological disorder. Now, I accept that sometimes it's clear that people haven't joined the dots around the different types of symptoms, and so they may not have actually described various things before because they haven't brought them all together as maybe being associated with each other. But on the whole, there's a huge variability to the way in which people present and the way their story unfolds, which I find unusual and difficult to explain in terms of the anatomy of the sorts of issues that we're talking about. And is there a relationship or an expected relationship between things like growth and development? Why is it that, for example, in the absence of trauma, we might suddenly see somebody present in their 30s and were well in their 20s? Didn't they have the risk already innately in them, if we're arguing that this is a tissue laxity issue? What has changed? So what then is the pathology? What are the possible mechanisms? And some of the thoughts that I think we all have, and we relate to our kind of interpretation of the presentation and our treatments, is that there may well be a relationship between sort of functional deterioration over time, deconditioning, the associated functional deterioration that comes from deconditioning, and then the deconditioning, you're in this vicious cycle. Maybe one mechanism over time that leads, if you like, to the exposure of a previously innate risk. But then also, what are there differences in risk, and why might there be differences in the presentation of heritable disorders of connective tissue, in particular the subtypes of EDS? Why do I see a lot of this in hypermobility spectrum disorder and hypermobile EDS, and very little of it in classical? Could that simply just be a numbers issue? Have I just got a very large number of people who have hypermobile EDS because it's the much more common variant, and therefore will naturally see this more often than I do in the classical? But then also, if there are more profound tissue laxity issues in some of the rarer variants of EDS, why don't we see it more profoundly presenting in those patients? So I hope I'm getting my message across. I find it really challenging to understand this from a causality point of view. So What about symptoms and signs? This for me is a very typical scenario in clinic. Patients are very well read, as you alluded to earlier, and they come in very much with a concern that they've got atlantoaxial instability or they've got craniocervical instability because they present with a number of symptoms. And the symptom presentation that I've listed here: headaches, neck pain, double vision, vertigo, tinnitus, swallowing difficulties, maybe even gasping for breath difficulties, symptoms of the autonomic dysfunction that we've heard about already first thing this morning, numbness in the arms and legs, clumsiness, maybe even both anxiety and depression that are primary or a response as a consequence of trying to handle and understand all of these symptoms, and sensitization to different symptomatology. You look at that list, and I think you instantly recognize, if you're familiar with this, the whole concept of cervicomedullary syndrome. Sure, that's cervicomedullary syndrome on paper. But if you look at the challenge in the other column, the problem for me as a physician dealing with somebody who has extremely complex presentation is that there are a number of reasons why any one of these symptoms or many of these symptoms in combination might present to my clinic. There are a number of reasons for headache, and I'm sure we'll hear much more about this later on. We have very specific examples in EDS of propensity to migraine, TMJ dysfunction, etc., etc. Neck pain is extremely common, as are visual disturbances. Tinnitus is just very common in the general population. Autonomic symptoms we've talked about, and so the message I want to get across is that I think that patients will naturally understandably be very concerned about the potential signs and symptoms, meaning that there is a cervicomedullary syndrome, and there may well be, but the problem is that there are multiple other reasons why they may have those symptoms, and that is an enormous challenge for us as clinicians to unpick that. So then, symptom causality is very often multifactorial. That's the message from that previous slide, and it's apparent to me that the presenting features that might look like cervicomedullary syndrome have numerous alternative explanations in the vast majority of my patients. And so I spend an awful lot of time in my clinic, and I'm sure my allied health professionals spend an awful lot of time as well, as do our clinical psychologists, on unravelling that for very many people who have otherwise come in very concerned that they've got CCI or AAI with cervicomedullary syndrome. So for each set of these symptoms we need to consider in their own right, and we need to consider them regardless of the presence or absence of a hypermobility-related disorder. We need to consider them in the context of the associations that we understand in the hypermobility-related disorders, and we need to also consider them in the context of a neurological syndrome. So there are all these layers of things going on that I think are, for any generalist in medicine, are enormously complex and very challenging. They're very difficult for me, and I've been doing this for a long time. Here's one example of that. Let's just take headache and neck pain. So in headache and neck pain overall, the pathophysiology of the pain is likely in our patients, from what we understand of EDS in general, to be multifactorial. I'm grateful to Anne for sort of fleshing this out for me. But we recognise that there could be a nociceptive problem which could be derived from any of the anatomical structures or muscle overactivity, overloading of the fascial tissues. There's all sorts of reasons why we might see nociceptive pain. Neuropathic pain, we recognise central sensitization as a concept, and of course this leads very much to aberrant movements, changes in kinematics, and we often find that with all of the different sort of treatments that we might engage with from a conservative point of view, that many of the symptoms can remain unresolved, and so we have these considerable challenges, and they were nicely written about by Marco Castori and colleagues a couple of years ago. The next point I want to get across then is that I think all of our patients, whether they might ultimately require surgery or not, are multidimensional in their presentation and require a sort of multi-specialty approach. And it picks up on the comment you've made about multidisciplinary teams, and I'll pick that up in my kind of wish list at the end with my last slide. And I just put this slide up just because as I'm working through things with my patients, I have these bubbles or boxes in my head, and I'm exploring for each one of the symptomatologies and the various possible diagnoses, what the physical, what the physiological, what the functional, what the social, what the behavioural, and what the mental health aspects of this are, and where we might, within the auspices of the multiple specialty team, draw on everybody's expertise to help manage those various elements. So what then about assessment and measurement? I've taken a history. I'm trying to identify whether I can pick out particular pathologies from the various investigations and assessment tools that I have. How close can I get in my clinical practice to feeling confident that I have actually primarily got craniocervical instability as the most likely diagnosis? Well, the answer for me is that it's extremely difficult to know whether I can be, very, very confident that that's what it is. And so, if my referral rate towards neurosurgical colleagues is, it may be high. I don't know. 5 out of 30 isn't that many, and 30 out of 250 is less than 10% of my population. But if my referrals to my neurosurgical colleagues seem a bit woolly, it may well be because, quite frankly, my assessment at that point is woolly, and what I'm needing now is somebody else who is much closer to the truth about the next step to give a more detailed assessment for me. I don't think I've ever referred with an expectation that surgery was the treatment that was required. It's always been help. I'm not sure whether we need to take this next step or not. So I am unaware of any studies in EDS that inform us as to whether there are specific clinical assessments or measurement tools of the symptoms for CCI that are more or less appropriate for EDS. So we use what we've got, but I don't have anything specific. And we've been exploring this because we are beginning to sort of think about this more from a research perspective in our own unit. Optimal imaging. This is really challenging for me. I have access to upright MRI. I have access to dynamic plane radiographs. I rely on the support of my neurosurgical colleagues to have access to dimensional CT scanning to inform us of what's going on. But when do we do this? What do we do? What is the most appropriate? There's no kind of guidance on that, and it comes down to a gut feeling from clinical experience. Then the challenge with the imaging is the interpretation of the imaging, the correlation of the findings on imaging with symptoms, whether the imaging findings actually inform our approaches towards any conservative treatment, let alone whether they inform anything with regards to surgical intervention. And actually whether they themselves change with conservative treatment. We have many other investigative tools that we use in medicine where we look deliberately for improvements in the evaluation of them as we treat our patients. Is there a requirement to understand the changes in the dynamics of these imaging findings with treatment? And I also find that language is really important in the reporting of these kinds of images. Extremely important. And this is my first example of where I think we have we have to be really cognizant of extremes of behaviour and extremes of language, both from a professional perspective and from a layperson perspective. I've had 1 or 2 people come into my clinic saying, I have been told on the basis of my imaging that if I don't have surgery, I'm going to be in a wheelchair and I might die. Now, when you look at the patients, they've been living with whatever they've been living with for probably the last 10, 15 years with their symptoms, and it's not clear to me that they're about to end up in a wheelchair or they're about to die. And that's one extreme example of language, but given the world we live in, social media, the challenges for our patients overall, let alone just this discrete area, I think we have to be very, very careful about the language that we pick. and choose. I also think that even using words like instability can be quite difficult and damaging when there are mild changes that one can see that are then left to the clinician to interpret. And you know, I liken it to there is a soft white patch in the vertebral body on an MRI scan. We all now know that means primarily that it's something benign and that we're not going to worry that it's a tumour in the spine, because we understand how these things are reported. But I still think that there is a gap between understanding the concept of excessive mobility and some instability in our EDS patients, and whether that leads to a pathology or not. So what about treatment then? I think that we continue to work with first principles. We use general standard treatments. We are lacking, I think, as a group as a whole, evidence for non-surgical conservative treatments. But if you look at the specific elements of the management of CCI, and I draw really on Professor Henderson's group and their publication in 2017 on this, the sort of key areas that we would be exploring with our patients are things like the role of a neck brace, physical therapy, avoidance of activities that provoke exacerbation of symptoms. I'm going to come to that last paragraph in a moment because I will pick up on that in a bit more detail. But for example, with neck braces, which neck brace? What's the most appropriate duration of use? What tools do we use to assess whether somebody might be suitable for a neck brace, and how do we assess that? Another example of an extreme behaviour, we put somebody in a neck brace because we felt that it might be useful, and she was certainly relieved of her symptoms. She went off to see another colleague at St Elsewhere. The neck brace was supposedly removed with a gust and thrown in the bin, and she was told that she should never put it on ever again. Now, that person may be right, but those behaviours and that extreme disbalance between one view on one hand and one view on the other is not helpful for patients, and it's very unhealthy for us as professionals. And I think we need to find a way to bring everybody towards a better middle ground. Now, indications for surgery are described as severe headache, symptoms which constitute the cervicomedullary syndrome, neurological deficits, referable to the brainstem, radiological findings, and failure of reasonable course of non-operative therapy. So let's just have a look at those, because these are the things that my patients read, and that's why they come and ask me what should they do. Well, it would be foolish of anybody, I suppose, to not realise that if there is a neurological deficit of any form, something urgent needs to be done. I think we all agree that. It doesn't matter what the diagnosis is. Nerve entrapment, brainstem, compression, sure. That, I think, is straightforward, and you would expect to find the profound neurological signs and symptoms from that pathology. But as I've alluded to, what then of severe headache, given the multifactorial nature of severe headache? Given that the symptoms that constitute cervicomedullary syndrome are so difficult to separate out from the multiplicity of symptoms that these patients have, what do we do with that? Given my concerns that I've flagged around radiological findings and their interpretation in our patients of CCI, what do I do with that? How do I use these to determine whether I should take the next step and refer on? More so, what constitutes a reasonable course of non-operative therapy? I went and I had a look for evidence, looking for methods and outcomes of conservative treatment of neck pain, headache, or CCI in EDS. And I just want to show you the evidence I found, and that's it. Okay, that's not the end of my talk though, because that doesn't mean we don't do anything, because you'd wonder, well, why do they come and see us? Why is Anne really busy in her clinic? And of course they're busy because they're using first principles, where there is a whole literature on neck pain, headache, trauma, physical therapy in the general population, so we apply those principles. If you look at the concept of something like whiplash-associated disorder, which may be something close to a laxity disorder, there are a number of different areas that are described in whiplash, which are very, very familiar to us conceptually in the world of tissue laxity. If you then think about maybe hypermobile EDS and HSD in particular, our patient population have multiple areas of pain, and we spend a lot of time trying to reduce those sorts of symptoms by focusing on control of joint movement and improving motor patterning. We spend a lot of time focusing on functional goals, training responses, and adapted physiotherapies, and these have all again been beautifully written about in terms of an evidence-based rationale back in 2017. And so we apply our understanding broadly of the management of joint hypermobility to a wider knowledge that there is in the general literature on pain and traumatic injury. But we don't have any direct literature. So my summary, my summary 2 slides and then my ask are that I think that day to day in clinic, as I work with my patients, I have considerable challenges identifying those that are at risk at an individual level and the reasons for their presentation. It's often multifactorial, it's extremely complex. It's very difficult to separate out symptoms that you could directly ascribe to craniocervical instability from the other pathologies that I've alluded to. I find it extremely challenging in clinic to assess for the presence of craniocervical instability clinically. And then what is the role of imaging in understanding that clinical presentation and the treatment options, and whether we can make any inference in terms of outcome. We have a lack of evidence as to how to safely and effectively strengthen the neck in a functional way in EDS where there is instability. So, if we refer patients back into the systems that they've come from regionally or nationally or internationally, unless we've got people who are working with us on the fringes of sort of normal best practice, colleagues are not familiar with this, and it's quite difficult to articulate to them the nature of of what we do. What does an exercise program for CCI and EDS actually look like, and what are the measures that we should use to assess symptoms and improvement? What's the impact of the related conditions, including psychological health on presentation and response to treatment? These are all big questions and certainly areas that we wish to explore in our unit, and I think remain big questions amongst all the colleagues that I talk to internationally. So I think that a first step here, even if it's not perfect, because we've got lots of things we need to answer, is to try and formally collate an evidence base and a guidance that at least gives some consensus to our overall approach. I suspect that we're probably within this group doing things roughly similar to each other, but I bet even then we have differences. The clinical assessment. What should we be looking for from symptoms and signs? How do we handle the differential diagnoses and the function and the impact? And how do we work on that in a multidisciplinary way? How do we land comfortably the criteria for the interpretation of the imaging? And should we be changing the language that we're using in this particular patient group to better reflect the normality in some of these patients as opposed to the pathology in some of these patients? Conservative management, we've got lots that we need to explore to understand. I call it gateways, referral gateways. What really are the indications for referral onto neurosurgical assessment? Because so much of the conversation in this area is around surgery, but far, far more patients are being seen for conservative non-surgical work than there are ever having surgery. And across the board, they all share the same concerns and complexities. It's not for me to talk about surgical management, but I would like to flag that I don't think that we've even really explored the rehabilitation post-surgery and how that is handled. So I think we need to be looking at trying to land that as a consensus. We need to be identifying coordinated multidisciplinary teams with consensus pathways for assessment and management. And what I'd really love to see come out of a meeting like this is a process of trying to establish recognised MDTs, both in the NHS and in the private sector, that really can be at the forefront of trying to help those most complicated patients first, but actually then that kind of rippling out in terms of the important messages around supporting those people who don't need surgery, who never needed surgery, but clearly have a lot of symptoms that we need to understand. So on that note, thank you.
it's an excellent talk, and almost we covered everything which we all have a controversy and also difficulties as doctors when we are dealing with the patient and the patient who have all these sort of problems. So now they were open for questions, please.
What percentage of your patients working and manage to stay, or come to you still working and manage to stay working, and what percentage become disabled to work, but then return to work?
Yeah, I can't answer that question for you directly. I don't have those figures in my head. What I do know is that many come after a number of years of symptoms, and those symptoms have functionally had an impact that stopped them from working, and that they have an aspiration to want to get back into those things. So they have those goals, but their recovery and their response to treatment is very, very slow. Equally, there are people who are working part-time, full-time, studying part-time, full-time, who kind of manage to do that with a plethora of really quite challenging symptoms. So it's a potpourri, and I think really we take a very individual by individual approach. They're all remarkably similar, but in each way they're all different.
I have a sort of ambivalent feeling about MDTs and search for consensus, where you don't really know what's going on. Mm-hmm. And you have to be careful, and this comes out of nice guidance in some conditions, that you find yourself constrained by a consensus that's been set up for all best possible reasons, but actually then inhibits clinical practice. So you have to be very careful.
Yeah, I think you're absolutely right. I probably didn't say it as broadly as I might have done, but I think we're very aware of this in many other areas as we start to develop guidance within the whole world of EDS. That the guidance that I think we should develop now should be based on our best understanding of what's going on, with many caveats that we need to look at this or we need to look at that. We need to understand all of these things much, much more, and that comes with having a consensus around databases, around sharing information, thinking about research projects together, so that we are not stymied by only doing what we know now, and that we are allowed to sort of move forward. I think the other thing about this is that you can often learn by those really unusual extreme cases, as opposed to the wider generality. And so if I were working in an MDT, I wouldn't necessarily be trying to stick to the letter in the middle. I would be really interested to better understand the decision making around some of the really challenging stories and presentations. So that's why I'm not proposing that there would be multiple centres all over the country or multiple centres all over the world that would do this. I think it probably requires a small number where there are people who are giving considerable thought to each of those individuals and what that might mean in terms of the wider exploration of what else we should be doing to understand this. So it's a starting point as opposed to what I feel at the moment is it's not chaos, because we're all here today and this is organised, but it's somewhat chaotic. I don't really get. I see my two colleagues over here who I've referred several times. I don't get a chance to really sit with you and talk about our patients. That to me feels wrong, because these are really difficult patients, and I need to be able to explain my concerns and my feelings that which are difficult to impart in a letter. Having had the patients assessed, they come back to me and will say something like, "Mr. Casey doesn't want to operate on me," in a way that somehow that's Mr. Casey's fault. And it's like, well, that's not. What we've done is we've had a neurosurgical assessment who says you don't need an operation. Great. Now let's move on. There's a lot of challenge in the system, and some of this is driven by social media, but some of it's also driven, I think, by us not actually having a structure where we dynamically talk with each other and share our approaches in a multidisciplinary way. There were a couple there, and then maybe Fraser.
a comment and then a question if I may. So you raised a very important point about the blurring almost between symptoms and more objective evaluation, for instance, of laxity. And I think that that's a key, and I think it's much easier for us in a way in the autonomic field because we've got very clear objective markers as it were, as compared to what you said has been descriptive now, but and objective in a way, but not as well compartmentalized in terms of that. And I just think of what is, I know mathematician, and I might possibly you being Newton, the Gaussian curve, because with blood pressure, normality could be, you average 120 by 80, but you could have somebody who's 110 by 70 who's perfectly normal,
Sure.
had no problems, and which is part of this big debate, the Platt-Pickering debate as well. So I think that's an important area. Quite how one addresses it in an objective manner as possible is difficult to know.
Yeah.
It is needed.
Yeah.
My second is, you talked, I think, about growth spurt, didn't you? What is growth and development? Now, interestingly enough, I've been, just by chance, we were talking about seeing more young males, as it were. This is, again, you're talking about POTS now. And with many of them, it's been linked with a growth spurt. That's one of the observations one has made with these people. And I wondered whether you had any thoughts, particularly on the connective tissue front, as it were, whether it could be impacting because vasodilatation, because of lack of connective tissue, of course, could be worse than POTS. So, thoughts?
So the reason, first of all, the Gaussian distribution concept. Of course, what we'd need to do is look at the whole population of hypermobility and understand what the distribution is, because an assumption that it's a normal distribution could be highly incorrect, and it could very much be that many of the features that we see on imaging and many of the findings that we find clinically, regardless of symptoms, are actually very normal in a very skewed distribution. We don't know because we haven't done that kind of epidemiological work. I have a sense that there's nothing normal about this, including the Gaussian curve. It's very, very difficult. With regards to my comment about growth, I guess what I was alluding to there really was that my paediatric colleagues and my adolescent colleagues don't come and tell me I've got patients with craniocervical instability. And they're really worried. I mean, I wonder really amongst the surgeons who have the most operating experience what the average age is of the surgical procedure for what's considered to be critical. And so my question is, if there is an innate laxity to the tissue, why don't I see it when somebody starts their teens growth spurt? Why don't I see it when they're in their young adult frame? Why are the patients presenting to me, significantly later? How do I relate that back causally to tissue laxity when really that innate risk, I assume, has been there all their life? Now, that's just me hypothesizing. The natural history of this in our patients who do have craniocervical instability, I'm not sure we know. We might know how long they've had the symptoms for, but I'm not sure we really know what was happening to them biologically during the stages of their life. So I'm alluding to this unusual observation that people seem to come to me quite late on, when you might have expected them to have presented at a much younger age. Fraser.
Just a thought, but kids have far better posture than adults.
Yeah. I mean, that's why I alluded to the could this be functional impairment followed by deconditioning followed by more functional impairment, because there may well have been an innate risk that was less of a risk because the individual was fitter from a musculoskeletal point of view at a younger life. It begs the same question in a number of areas of injury in hypermobility. Why suddenly at the age of 22 is the shoulder subluxing? There's suddenly more pain. What's changed from somebody who was actually quite fit before, who actually could do well in sport? Why has it changed? And often you find that there's been some event, and that has led to a change in function, and that has impact in terms of quality of the musculoskeletal frame, and it kind of it evolves into a more systemic problem for them. It almost exposes the innate risk, which wasn't there because they were fitter before, as one hypothesis. I think Manjit had a question and then Fraser.
Yes. Thank you for an excellent talk. Yeah, absolutely enjoyed that. Lovely. Two things. Firstly, you mentioned that the social media is to a certain extent driving this, yeah. But I'm going to just back up your comment. I think you're alluding to the fact that some of the clinicians don't actually have the situation either in the UK. And I'm certainly aware of a radiologist who actually takes a patient aside and tells them at the end of the consultation, after the radiogram, after the scan being done, that they've got craniocervical instability and they need to see someone urgently. And I'm not really sure that that's the role. When you send you out to radiology, when you do the scan, the patient goes away, the report comes to the clinician. And I find that really disturbing. And I have some very awkward conversations with those patients here, where they tell me, but I have been told by this radiologist that I'm going to die if I don't do something about it. Something needs to happen about this. And they're telling me this is not even something I should be considering. It becomes very awkward here. I don't know, the group that has to actually say something to some of the radiology colleagues that is not the way to conduct themselves here. Just a thought, just to put on the table. I'll also come back to the point that I think one of our delegates was making earlier on. I'm concerned about having guidelines in an area where the evidence base is largely non-existent. And the difficulty with that is maybe giving the impression that there are things that are right or wrong to do. But in essence, I think what we really need is an agreement about how we should move forward on research. I don't think any of the patients who are being considered for CCI should be in anything other than a research study.
Right.
And that research study, looking at whatever it is, whether it's open label, whether it's controlled, or whatever we do here, I think we should more or less think that, as a group, we're going to plug everyone to a research study. We need to follow this people over a period of time and figure out, what we do. And of course, in a number of 5 years, that you yourself as graduated, and I'm very happy that my work is very much along the same lines there. But I think that's what we need, more than a guideline.
Yeah, no, and it's interesting, isn't it? Because again, it's about language. So you might have one concept of a guideline, I might have one concept of a guideline. My concept of a guideline might be, do you know what we don't know? And so right now, what we're asking you to do is to go back to first principles. But what we'd really like to do is we would like to take that patient group and explore them this way in terms of treatment and outcome studies. That patient or that subgroup then need this. So traditionally, guidelines are very much built on there being lots and lots of evidence base, randomized controlled trials, etc., etc. Maybe it is just a guidance. Maybe it is just a statement, which is a consensus statement on the state of play that we need. But I think we need something, because there are extremes. There are extremes. I have sat with patients who have been told, based on their imaging, that their head's going to fall off. They probably haven't been told those words, but that's what they've taken home. And of course, they come in with huge amounts of understandable anxiety and everything else. And I look at them and examine them and think about everything that's going on, and I have to try and talk them down from that. I have the huge advantage of being hopefully respected as somebody that's worth listening to. But actually, if you're out in the field and you're not, and you're trying to talk to a patient who doesn't perceive of you as an expert, you might still have exactly the same concern and conversation, but it's not perceived that way. It's almost perceived as negative. You're not listening to me, and it's those extremes in terms of our reactions to these things and the responses and the relationships that we have a problem with. And I just feel that trying to get more people to realise that there is a middle ground in terms of what we need to do next is really important. The other thing is of course the extremes in our behaviours. I don't know whether it was right for this person to whip the collar off and throw it in the bin in front of the patient in clinic. It doesn't feel like a sensible professional behaviour, full stop. But the essence of it might have been, you just don't need this collar. And they may well have been absolutely right. But that doesn't matter. It's all completely by the by, because the patient came rushing straight back to me via email and said, what the hell do I do? And I'm like, well, I thought we had written a fairly logical protocol as to how we were going to take things forward, and now it's been trashed. literally. So we have these enormous professional challenges, and I think a huge responsibility to our patients to be able to articulate that where we are now more clearly, to support them in understanding their situation. Fraser. I'm taking up a huge amount of time here.
Quick comment. I agree that these patients should be on an IRB protocol. I do have 3 IRB studies. I'll give you them to read. Concerning the patients, the average age is quite young. And usually when I see them, and I've seen about over 2,000 new patients now, most of them report symptoms going back about a decade, but they became much worse with increased estrogen levels.
Right.
They're often triggered by mast cell activities or infection or trauma.
Right.
But my comment is about the craniocervical, so the cervical medullary syndrome. In the United States, there's a ICD-9 category that's called craniocervical syndrome. So it's well recognized, and it's based on the symptoms that we see with Chiari's and basal invagination and lesions of the craniocervical junction. And a large series, many hundreds of patients that report the same symptoms over and again. In 2013, we had a multi-institutional meeting in San Francisco sponsored by the CSF with 17 different institutions, and we settled on the cervical medullary syndrome as an aggregate of symptoms which, taken together, often reflect pathology at the craniocervical junction. Now, obviously, vertigo could have 100 different causes, but if you have vertigo and diplopia and choking and dysphagia, dysarthria, if those symptoms occur together, it's often because there's a common underlying cause. Hakims raise that. So the NIH has now adopted these same symptoms, the cervical medullary syndrome, and I think I know the term cervical medullary syndrome may not be as commonly used in the United Kingdom, but I think in the United States it clearly refers to symptoms that are generally recognized as developing from pathology of the craniocervical junction.
And absolutely, and please don't get me wrong, I completely recognize the concept of the syndrome. The enormous challenge for me is that in syndromic patients overall with multiple complexities, each one of those could potentially be related to something else. And so I'm seeing somebody who's syndromic with a possible syndrome, and teasing that out is very difficult. And if I just think about how we then interpret, for example, upright MRI, I have had very, very few scans ever come back actually showing that there is any sense of a pathology in the cord or the brainstem. So lots of description of instability of different types, but no evidence that somehow there is something wrong with the brainstem. So how do I then, as a general clinician, interpret the possible presence of cervicomedullary syndrome with the absence of any evidence of any pathology in the cord? That, for me, is a huge challenge. At the same time, dealing with multiple other reasons why these patients have these symptoms, identifiable other reasons why they have these symptoms. I give you one scenario of somebody, I don't think I'm giving anything away, HIPAA, GDPR, etc., of a case on paper, cervicomedullary syndrome, MRI done, some instability, impression in the report without seeing the patient, needs cervical spine fusion. Comes to our clinic, has got four other definite pathologies that are all driving multiple symptoms that are all similar to the cervicomedullary syndrome, 2 of which are eminently treatable. One was an autonomic dysfunction related to cardiac disorder, and the other one was a mast cell activation, not syndrome, but urticaria and angioedema. Got those treated. Many of the symptoms settled down, not a whiff of a suggestion that the neck was ever involved. She nearly went for surgery.
Yeah, I've seen patients like that too, and I agree with you.
I'm concerned because I've taken up all of Rodney Graham's
Take a
time.
question from Laura.
I just wanted to pick up on the comment that was made about social media, and I think critically that the reason that there are such sensationalised headlines in this country, I'm dying, my brain's falling out, is because there's been no other narrative. The narrative in this country is being led by very, very frustrated patients, and I think the best outcome that can come of today is that something will be done, even if that's which I think should be moving towards research, conservative management. It's the lack of any narrative by the medical professionals, by commissioning, that has been the issue, and that's why it's really discrediting EDS and this issue. So something I think will start to help lead that discussion.
I agree, Laura. I think where we have failed is that we haven't actually put out a narrative that this is not just CCI. There are a number of other causes, and more of them obviously other causes are important, and the result is a likelihood of CCI that you mentioned. And because we haven't put the narrative out, I think we're losing out.
Absolutely. It's the lack of anything that's causing it.
I think what I would say, maybe just to close,
Just one question for me. So those 30 patients which you were 10% you refer to the surgeon and the answer came not for surgery. What was their level of satisfaction when they came and see you after seeing the surgeon? Were they happy, they satisfied surgeon had decided rightly, or they said no, they are going to somewhere else now?
Yeah, so even despite my attempts to explain to them the reason for the referral for the surgical opinion, dissatisfaction that they weren't having the surgery, because I think understandably, it's a definitive procedure, there's a step towards a potential improvement, but then a lot more conversation afterwards. And I think one of the other observations for me in terms of the complexity of this, the challenges of this, is the amount of time that you have to dedicate face-to-face with patients to be able to talk them through the initial understanding of things, and then, if you like, the sort of rehab from the referral process, and then the rehab into better health. It takes a huge amount of time. I get very long emails from people, I have very long phone calls with people, I see people for an hour at a time for follow-up. It demands a huge amount of input to support them, which I'm very happy to do, but I'm completely aware that most people just do not have those sorts of resources available to them. It's enormously challenging. What I would just say, if I might, just as a final reflection, is that I put this all down on paper yesterday as a PowerPoint. This is my very first outing of this kind of talk, and I'm deeply relieved that I've obviously hit a nerve, if you pardon the pun, and that colleagues are receptive to this, because this is my day-to-day challenge, whether I'm right or wrong, whether I've not necessarily articulated it fully, or I've maybe used, said something contentious. But this is my reality, and actually, if it's 90% of everybody else's, we've got to do something about it.
No, I think you're absolutely right. Thank you very much. Very kind of you.